So without further ado, I think we should move to our first work group presentation, which is on patients and residents, and Theresa and her team will cover that. So Theresa.
Good afternoon, everyone from Washington, D.C. It's sunny and a little chilly here, but warmer than it's been for the rest of the week. I'm happy to be with you today and talk about this very important topic and reflect on what an engaging work group and hardworking work group we had yesterday to address racial inequities. I'll be joined in the presentation today by Sarah, Tanya, and Carol. But at the end of our session, I'll also invite the members of the work group who participated in this discussion to add their reflections. It definitely was an intense conversation and we covered a lot of ground. So we'll hope to do it justice today. If you could go to the next slide. So on day one, we had some really intense discussions as well. And Chris shared these reflections yesterday. One of my takeaways from day one is that anytime we're having conversations like this, we need to deliberately work to incorporate residents' voices in creating solutions. And to work with them to address some of these issues of intersectionality, racism, ageism, classism, even sexism, as so many of the staff and residents are women, and many of the leaders are still not. Residents of color, many of them live in majority minority nursing homes that have fewer resources, including lower staff levels. Residents are already vulnerable and may feel controlled or exploited in a system that often uses their care to make a profit by design. And leadership may not always include people of color, though many staff will, and many immigrants are. And when leadership is more diverse and culturally competent, we learn this can have a good benefit because residents and families of color may have louder voices and feel better understood and respected. In many ways, a lot of these themes did come down to two critical concepts of power and respect that we discussed a lot in our work group. And culture change practices can help promote that level of respect, and person-centered care can help residents live their lives in the way that they want to. But there are challenges, and these challenges are similar whether we're talking about racial inequity among families, among staff members, or indeed among leadership and leaders. And one devalued and disenfranchised population is often taking care of another in the nursing home setting. All of these issues have been exacerbated by COVID, as we all know. And we have to remember that even when they may look alike, residents and staff are not peers, and there is a power dynamic that we need to be conscious of. So these themes that we alluded to yesterday really formed a foundation of much of our discussion during the work group. And the first thing that we did after laying the table and doing some introductions is we pulled together a word cloud, which is on the next slide, that we used to pull out the top challenges, the core issues for residents and families. And you'll recognize some of the words on this word cloud. Respect of residents for each other, residents for staff, staff for residents, staff for family, mutual respect that underlies many of these relationships. That's the other big word that came out. Perhaps even bigger than both of those words is the concept of quality. And when we talk about quality, we can mean a lot of things. We can mean quality of care, we can mean quality of life, we can mean quality measurement. So one of the things that you'll learn, we talked about in our elaboration of the challenges and development of the solutions, is moving toward quality and what that might look like in a situation of respect, of cultural competence for residents and families of color. So with that, I'll turn it over to Tanya, who will tell us a little bit more. I apologize. I got my process wrong. To draw out some of these concepts and elaborate them in more of a structured fashion, we used a technique called a Trello board. The next slide is a picture of the Trello board that we used to develop our discussion. And my colleague Sarah is going to tell us about how we used it.
Sure. Thanks so much, Theresa. Hello, everyone. My name is Sarah Khan. I'm delighted to be speaking with you all today and to have worked with you guys over the last couple of days. So over the last 2 days, we've engaged in such rich discussions about racial inequities in post-acute and long-term care. So in our resident and families work group yesterday, we used a pretty nifty tool called a Trello board, as you can see here. And by using this, we identified and sorted the contributing factors of racial inequities in nursing homes into different core challenges or themes. So as you can see, there's policy and regulatory, social cultural bias, institutional medical model, education, training and research, and inequality of power. So once these categories were sorted into these challenges, we also listed actionable items that advancing excellence can take away from this list. So I will now turn it over to my colleague, Tanya Roberts, who will dive a little deeper into our prioritized core challenges and their contributing factors.
Great, thank you, Sarah. Next slide, please. So what I'd like to do is give a little bit of context around the group's discussion on our 5 major contributing factors or challenges. I'm going to start with talking about the 3 that you see in gray, as our group sort of endorsed the green and yellow challenges as high priority. I'm going to sort of wrap up with those. What I imagine you're going to hear as each of our work groups sort of report out today is a fair amount of intersection and overlap between what we've recognized as potential challenges contributing to racial inequity in long-term care, as well as potentially some of the actions. So what I really want to do is try to focus the discussion here on how these specifically apply to residents and how we saw each of these categories really impacting the experience of residents. So the first one I want to talk about is policy and regulatory issues. And there's really sort of 3 major ways we saw policy and regulatory challenges that contribute to racial inequity. The first, existing policies and regulations really underemphasize the provision of care that's culturally competent and promotes racial equity. And so this is evidenced, for example, by the lack of attention to racial equity and a lack of training for surveyors on identifying care that results in discrimination or inequity. There's also sort of a lack of accountability provided for by our regulations for supporting resident quality of life and racial equity, especially due to a lack of standardized measures and a lack of reporting about discrimination and inequity. And then finally, existing policies around reimbursement for care, allocation of resources, and staffing levels do not support good quality of care. And they really exacerbate issues of inequality for residents, particularly those who are in segregated facilities. And then when we look at the institutional or medical model as another potential contributing factor, or facility operations, in other words, that lead to a culture that perpetuates racial inequity, we talked about how some operations, some models of care do not support person-centered care delivery, including the recognition of the unique needs of individuals, and the lack of support for staff to take actions that address and tailor care to the unique needs of those residents or those individuals. There's generally a lack of assessment and planning or specific attention to the needs of residents of color in some organizations. And the workforce culture in some places could lead to a lack of knowledge, poor attitudes and behaviors that could perpetuate poor quality of care, staff turnover, and the lack of person-centeredness. And then finally, the resources available in some organizations to support culture change are also lacking. And then the final gray box there on inequality of power is a really important challenge, and it's something that we discussed as kind of underscoring and cutting across all of the other contributing factors. And we wanted to specifically acknowledge that residents of color face power differentials, and these lead to disempowerment, lack of agency, and it prevents their voices from being heard. We talked quite a lot about the power of stories, the need to advocate for residents, and the need to amplify their voices. We realized that we need to reach a range of stakeholders and make them aware of the real experiences of residents of color, sharing their stories and promoting change to improve care. Next slide, please. And then just to focus in on the two areas that our work group endorsed as the highest priority, you know, all of the areas that we brought up are really linked to one another, and actions that we might take to improve in one area could also improve in others. But we really wanted to focus here for our discussion today. So the first one is social and cultural bias. And while I don't believe that any of us think that we're going to leave this summit completely solving the issues of structural racism, we certainly couldn't, or we'd be remiss to think that we can ignore it either. And so our group really talked quite a bit about how the culture of ageism, ableism, racism, and sexism have really led to a wide-ranging negative impact on residents. This bias has resulted in a lack of mutual respect, plantation mentality, poor relationships, a lack of cultural understanding, and it leaves our residents and families without a voice. It leaves them without support for getting their needs met and improving their experiences. Resource disparities and socioeconomic differences and implicit bias exaggerate and exacerbate these issues. And while these challenges run very deep, it's a place that we have to make real change. And Carol, in a moment, will tell you a little bit about some of the actions that we think we could take to try to make a difference here. And then finally, I want to talk about our final challenge on education, training, and research gaps. This is a place where we see the opportunity to commit ourselves to providing people with the tools that they might need to become aware of the issues that residents of color experience in long-term care, to become aware of their own responses and biases to these issues, and the tools to act on these issues to make change and improve care. So specifically, ensuring research on quality of care and quality of life includes rich data that highlights the experience of residents of color, may provide a story that explains the data on disparities and helps us identify potential opportunities for intervention. Staff education on person-centered care, cultural competence, and implicit bias may help individuals become aware of their unconscious thoughts and behaviors and give them the skills to change behavior and make improvements. And finally, education that helps empower residents and families to know and act on their rights without fear of retaliation is critical. So that's it for our background on challenging factors, and Carol will talk about our actions next.
Thank you all so much, and thank you for being part of this summit. This has really been a call to action for all of us. And now comes the hard part, really diving into what we're doing or what we can do to try and at least start to put a dent in these problems that we're seeing everywhere. So Chris, can you go to the next slide, please? One more slide.
So Carol, I can take this one.
Oh, okay.
Yep. So before we get to where we landed with the actions, I'll set the table, and then Carol will help us all eat a nice, healthy meal of action. So first we dug into social and cultural bias as a challenge. And this slide illustrates the different buckets of actions that we able to consider for addressing social and cultural bias, specifically for residents and their families. So first was to collect and tell stories at all levels. We've heard a lot of stories over the past 3 days. I think Maurice is able to join us today again. And so thank you for sharing your insights and your experience, as well as Arletta and others who dug in from the resident, from the family perspective and told their stories. That brings it home. That brings it home for me, and I think it brings it home for others in the world. So to broadcast those stories to a broader audience is something that our work group thought was very important. And we can collect even more stories using social media and potentially even create a marketing campaign to get some of those stories out there. We also need to keep having these conversations, lean into the difficult conversations even after this summit is over. Prioritize this topic in everything that we put out there as advancing excellence, and continue to push for person-centered care. The third of the action buckets is to advocate for measures, policies, and research related to person-centered care, health equity, cultural competence, and promote funding to help this happen, to address disparities, support research, measure development, and education. We also want to support person-centered and cultural competence training and figure out what are the core categories for such a training, what's out there in the landscape today that we could leverage. How can our members of Advancing Excellence and our broader networks incorporate these trainings into their meetings? And should Advancing Excellence be presenting at meetings as an organization or sending our members as well? And promote expanded residents' rights documents so that residents and family members are aware of what expectations they should reasonably have for cultural competence and person-centered care within their communities. So if we go to the next slide, we'll dig into the actions for our second prioritized challenge, which is the gaps that exist today in education, training, and research. And you'll notice that some of the themes and ideas here overlap with the cultural bias apps. So the first is to encourage staff education and training, identifying training materials that really explore these key topics. And then this one, Carol will talk a little bit more about in a second, walk the walk. So how can we all look in the mirror for our own organizations to see what opportunities there are to educate ourselves and the people who are a part of our membership and our networks, and in the case of myself, our client base, to help them understand these issues better. Empowering residents as well to use their own voices, potentially through resident and family councils, through educating residents and caregivers, supporting multi-method research. We had a very good point in our session. Lori shared that much of the research that's published on quality in nursing homes focuses on quantitative data sources like claims analysis, like MDS analysis, like the analysis of very structured patient surveys. And this stories, this misses the patient voices that really help tell us where our gaps in knowledge are. As a researcher, you don't know what you don't know. And if you only look for the measures and outcomes and data underneath the lamppost, because that's where the light is, you're not going to find them. Educate policymakers, regulators, and enforcers. So now that we've got the stories, can we bring them to the Hill? Can we bring them to CMS, advocate for measures and policies that we need, and make sure the survey teams and other people charged with enforcing regulations understand how important this is and really understand what they're looking for. So that was a lot of very diverse actions. And after our work group yesterday, Tanya, Carol, Sarah, and I all stayed on the phone, and we tried to knit this all together in something that was a little bit more both cohesive and actionable. So if you could go to the next slide, Chris, Carol's going to tell you where we landed.
Thank you, Theresa. And I hope you can see that we have really tried to drill down in an IHI quality improvement kind of way, where we took the challenges and the big problem and really said how, and why, and what can we do, and what's the best thing to make this very real. So we consolidated some of the actions that Theresa talked about. And the first one is in the green box: schedule follow-up activities to continue the difficult conversations and broaden the network of participants. And one of the things that Dr. Rabowski said to us so eloquently was that we need to start with ourselves, and we need to look inside ourselves to identify any hidden biases that could be there. It's so easy to, and we even caught ourselves yesterday talking about all nursing homes, and we had to pull all nursing home residents, and we had to pull ourselves back and focus on the racial inequities that we know are there in the nursing home, with the Black populations, the Hispanic or Mexican and Filipino and Asian populations that are in there. So we have to look inside ourselves to find any hidden biases that we have. One thing I noted about myself was that during our conversation, we were talking about our personal experiences, of course. And I remember when my mother was in a nursing home, it was important for me to find out that everybody was doing what they were supposed to be doing. Is everybody doing what they're supposed to be doing? And boy, after I thought about that, it was like, doesn't that sound like an overseer? Without looking at the respect for what people are there to do and the difficulties that they have. So we have to move forward and keep the momentum going. Number one is to look inside ourselves. Number two is for us to ask our Advancing Excellence members, and we have quite a few, that they go within their own organization and have the difficult conversations with their members. What are the long-term care associations doing about this issue? Are they doing anything? And what should they be doing? And then the third difficult conversation that we need to keep moving is, what kinds of programs do our partners have? And a couple of partners that we can immediately go to are looking at CMS, finding out what CMS is doing. When we were talking about the regulations, we noticed that the definition of person-centered care really doesn't get into racial equity at all, and perhaps it should. And then also to work with our ombudsman and really bring them into this, because they are right there at the bedside. The second big issue that we had was collect the stories from residents, families, and staff to illustrate the problem or the inequity. And again, we heard from Maurice, who is with us today. And thank you, Maurice, for sticking with us for all 3 days. We can't let you down, but we need more stories like Maurice's that we can use to tell people what it's like. This is where the rawness, the depth of what's going on is. And this is what we need to increase the awareness in order to get the research done that we need, and to get the work done that we need, all the way through the continuum of care. I was sort of struck that Dr. Grabowski quoted research from David Barton Smith that goes back to 1990, and we really haven't updated that research since then. So that when we talk about research and measures and what we should be looking for, what we're using is data that is sometimes 30 years old. And so we really need to focus on this and figure out what do we need to do to measure racial inequity in nursing homes. Right now, we can get the stories, but if you were to ask nursing home residents, are you happy here? Most of them will say yes, because they're afraid of retribution. You know, right now it's all that they know. So we have to come up with the right measures, and we need the stories to look at so that we can pull from those stories to look at measures, and really find out what it is like to live in a nursing home. And is it different if you are Black, Hispanic, or Filipino? We need the voices, we need the stories of the residents. So with that, I'm going to turn it back to Theresa, who's going to dive into these two of our action steps a little more, and give you a little more to think about.
So as we were thinking about the first two action steps, if you could go back to the last slide, Chris, that'd be great. If, as we were thinking about the first two action steps, we kept asking ourselves, so what? We're going to schedule follow-up activities and continue conversations. So what? We're going to collect stories, and then what? So to bring these conversations and the stories to the point where we're not just listening and learning, we're making change, that's where the second half of this slide comes in. So we want to schedule these follow-up activities and collect stories so we can promote education on implicit bias, cultural competence, and person-centered care for staff and leadership. Now, the hard part, of course, is going to be to figure out, how does AELTCC, how do the people on this phone effectively promote education? One of the challenges that I think we had in our work group is we all come from organizations that are used to making recommendations to providers. Providers should do this. So now we're challenged to make recommendations to ourselves. What can we actually do? And maybe that is making recommendations to providers. Maybe it's making recommendations to politicians and regulators, policymakers. So that brings to the second box: advocate for measures, policies, and research related to racial equity in post-acute and long-term care, and engage in projects to help develop measures, policies, and research. So all of these things for advancing excellence to have a role in require resources, require partners, require a plan of action. And this is where we did not get in day two, but I'm hoping we can start having some of these conversations towards the end of today, so we can make these actions feel more concrete and directive. But the whole point of this slide is that the engagement and coalition building actions that we're so good at already in advancing excellence can be translated into education and advocacy, keeping a few things in mind. And now we're ready for our last slide. And I think we'll then have 5 minutes for discussion, which is that we learned throughout this process that person-centered care and cultural competence are not the same. We cannot use these terms interchangeably. We need to intentionally acknowledge race, or we'll fall back into the culture change discussion we've been having for a while, which is no less important. It's very important to think about person-centeredness and promote culture change, but without intentionally acknowledging race, we may miss the mark for achieving racial equity. We need to think about the CMS definition of person-centered care and think about, could it be expanded to include cultural competence and racial equity? Look at guidance to surveyors, and then advocate for policies to include requiring training for implicit bias. So all of these were swirling in our heads, create the statement for nursing schools. All of these were swirling in our heads as we had the prior conversations. But I think we all just kind of need to think about where we're coming from. So Sarah and I both work for Discern Health. We're a consulting firm. We do advisory services and research working with our clients. So we're really good at creating frameworks and organizing information and helping other people move to action. So we need to think about, okay, well, what can Discern do to advance this conversation of racial equity for residents and families in nursing homes? And I would encourage you all, while we're having the conversation throughout the day, to think about your own organizations and how you can apply your core competencies and what partners we can leverage, as we'll talk about later on, to make some of this happen and make sure we're pursuing the right priorities. So I'll invite now the other people who participated in our work group who are on the call today to add their reflections. Did we get it right, guys? So I think Lori's on, and I think I saw Christina. Kathy, do you want to add anything? Well, while they're trying to figure out if they want to contribute, are there other questions for the residents and families work group?
Theresa, this is Kathy. I just wanted to say you did a great job, really, synthesizing all of this. And
you did a great job coming up with the ideas.
You know, we need to, I think, you know, it can be overwhelming. So I think taking one step at a time and working with Advancing Excellence to prioritize, you know, what they can do and what they can start with, you know, and all the organizations involved would be really good, because there's just so much. And that's only residents and families. We haven't heard from the rest of the groups yet.
So true. Other questions or comments? Janice, you're live. You're live with Advancing Excellence. Oh, maybe she didn't have a comment after all. Well, Sarah, Carol, Tanya, do you have any final thoughts before we turn it back to the team?
This is Lori.
Oh, Lori.
Yes. And I will say you did a really wonderful job. I just want to say thank you and comment on about emphasizing the importance of stories, because that came up over and over and over. And I sent a message to Maurice telling him that we need to clone him, because what he has done is so important. So I can't emphasize that enough. And thank you for putting that at front and center.
Thank you so much, Lori. And thanks for all of your thoughtful comments yesterday as well.
Certainly. It's been a great meeting.
Okay, well, I think we're out of time. Up next is the staff work group.
Right.
Yep, I just want to say thank you to Theresa and her team and the entire members of that work group for putting that very thoughtful group of actions together.